Okay, Goja, do you want to start?
Yeah, sure.
Yeah.
Thank you everyone for joining the call today. I'm Gorja Bansal, working as product manager in Premas Life Sciences. And in collaboration with Illumina, we are really excited to host this webinar around the recent development in technologies around prenatal diagnosis. With the increase in number of assisted reproduction cases and maternal age advancements, it's always better to consider the technologies that are recent and which can minimize the risk for the newborn baby as much as possible. And that's the only rationale behind keeping today's talk, one centered around the product overview, and another is the paradigm shift around the technologies. And really, we are thankful to Peter and Dr. Dale for kindly accepting our invite for the talk today. And it's my honor to introduce the first speaker of the day, Peter Coleman, who has extensive experience in working with different embryology labs and its setup. And from the last 5 years, he's working with Illumina as segment marketing manager for reproductive health and genetic diseases covering whole Asia Pacific and Japan. Before passing the ball to Peter, just want to share some housekeeping points. So we have kept all the attendees on mute. If you have any queries or any questions to ask from Peter or Dr. Dale, you can just type over the chat box. We will try to address all the queries towards the end of the presentation. Over to you, Peter, now.
Great, thank you very much, Gorja. Let me just share my screen. Okay, so thanks to Premas for organising this great event and for the kind introduction. And of course to today's speaker, Dr. Dale Wright. What I'm going to do in the next few minutes is provide a high-level overview of Illumina's new cytogenic arrays before handing over to Dale for his educational presentation. This is Illumina's new and improved cytogenetic arrays, Gsa Cyto and GDA Cyto. These arrays have genome-wide coverage across high-value clinical regions with an exon-focused design. They are built on the well-established GSA and GDA array backbones using the proven and well-tested Infinium B-chip technology. One of the exciting aspects of this product is that we've partnered with BioDiscovery to provide a comprehensive end-to-end cytogenetic solution. So let's take a look at these arrays. As you can see on the left, GSA array holds 24 samples per array and has around 700,000 markers. 80,000 of this is the new cyto booster content. The GDA array, on the other hand, is a higher resolution array and holds 8 samples per B chip. the cytobooster content on this array is around 160,000 markers. You can see that the B chip reader for both of these arrays is the iScan, and there's automation compatibility through Hamilton and TCAN. The additional targeted content was added for cytogenetic specific markers developed through a consortia with Biodiscovery. Marker input was obtained from ClinGen Pathogenic, DDG2P, OMIM, Mendeliome, and input from consortia laboratories. You can see here that around 5,000 genes of known disease association were focused on. Within these genes, probe placement was focused on the exons, providing greater confidence and accuracy in decision-making. Importantly, this is up-to-date content with a build year of 2020 for both the GSA cyto and GDA cyto. This Infidium assay workflow proceeds from input DNA to genotype report in around 3 days. It has a relatively low input DNA requirement of around 200 nanograms. The iScan is the array scanner, which is a very scalable platform. And as I mentioned, data analysis is done on Biodiscovery NX clinical software. This provides comprehensive curated annotation to expedite variant analysis and technical reporting. If you have any questions about GSA or GDA cyto, please reach out to the fantastic Prince team for more information. It now gives me great pleasure to introduce the focus of today's presentation, Dr. Dale Wright. Dale is the head of cytogenetics for Sydney Genome Diagnostics at the Children's Hospital at Westmead, Sydney. He has over 30 years experience in postnatal and prenatal diagnosis microarrays, first-trimester maternal serum screening, and SNP microarray analysis in paediatric haematological and solid tumour. Dale holds a master's in reproductive health and human genetics and a fellowship of the Human Genetics Society, and is a fellow of the Faculty of Science of the Royal College of Pathologists of Australasia in medical genomics. Dale is also a clinical lecturer with the University of Sydney for postgraduate studies in medical genomics. Without any further ado, I'm now going to hand over to Dr. Dale Wright for his presentation, Laboratory Practice Changes in Prenatal Diagnosis. Thank you, Dale.
Right, thanks for the handover, Peter. Just bear with me, everyone, while I share the screen and pull up my presentation. We've had to do a little bit of a juggle around this afternoon. We couldn't quite get my recorded presentation online, so I'm coming to you live to redo my talk, and just bear with me. Okay. Is that viewable by everyone? Can you see that okay?
Yes,
Presentation
sir.
okay?
Yes.
Yeah, right. Okay. Well, first of all, thank you, Peter and Illumina, for inviting me to talk today, and also Premise. It's a pleasure to come and, I guess, share my views and experience in prenatal diagnosis, and I guess some of the laboratory practice changes that we've made in prenatal diagnosis over the last 10 years at the Children's Hospital of Westmead. I've spent probably the major part of my career in reproductive health. I was the head of a prenatal diagnosis laboratory for a private IVF company here in Sydney. It's now known as Gsa, and we were one of the major and largest prenatal laboratories, diagnosis cytogenetic laboratories in Sydney. Okay. So before I delve in, I just want to make a declaration, a disclaimer, that I'm talking today and I'm not giving any opinion on behalf or for Illumina per se. I'm not giving any opinion on the products that might come across in the presentation. I have no other conflicts of interest, and I'm receiving no financial support or incentive for the presentation today. So I'm probably going to cover quite a lot today, and to help give a bit of an overview of the talk, I'm just going to briefly cover the changes in our laboratory over the 10 years, look at some of the population trends for prenatal diagnosis of chromosome abnormalities in pregnancies and why those population trends have changed practice for the laboratory. Some of the reasons that drove those changes, including demands for laboratory resources and including staffing, the change in technologies for rapid testing compared to karyotyping, also the impact of non-invasive cell-free DNA screening and maternal serum screening, and then finally about the emergence of chromosome microarrays in prenatal diagnosis. But before I get into that, I was also asked to speak briefly on the use of microarrays in products of conception or miscarriage material. And to take you back prior to 2008 at the laboratory, it was before my time, I wasn't there in 2008 at the Children's Hospital. We routinely at the laboratory did karyotype analysis of products of conception, placental material, fetal skin, cartilage bone, either from the first trimester, second trimester, or third trimester. And some of the limitations about that karyotype analysis really revolves around receiving viable tissue for adequate cell culture. And often pregnancies that miscarry are already necrotic and don't culture well. And so part of the issue is that often we have high culture failure rates and we can't get a result. Abnormalities less than 10 megabases of the genome go undetected. And some abnormalities like complete molar pregnancies with a 46XX paternal karyotype contribution only go undetected. And then also the results are confounded by maternal cell contamination. And so around about 2009, we started to use another molecular cytogenetic technique called MLPA, or multiplex ligated probe amplification, using subtelomere probes to try and see if we could screen or detect a chromosome aneuploidy. But it met with limited success. And so from 2010 onwards, we started to perform CGH microarray using an 8x60K ISCA targeted design at the time, partly because we already had this microarray in-house, looking at postnatal testing for development today, intellectual deficit in young children. And the other reason that we didn't need viable tissue, we just had to get DNA from the products of conception material to form the array. And just a quick overview of some of the results that we put together around about 2011 now. You can see in the top graph here, we've got success rates and abnormality rates for karyotyping on the left. And sorry, I'm just going to put my pointer on, laser pointer. Yeah, here we go. So karyotyping on the left compared to microarray results on the right. And you can see in the green here, these are the success rates, which were quite variable, 37, 40 to 50%. So really we were not growing placental tissue or miscarriage material unless in more than 50% of cases. And in those that we were successful, we had variable abnormality rates, 14%, 26%, 7%. So it was clear that we weren't providing the best service and we weren't good at growing material from miscarriages. On comparison, when we look at 2010 and 2011 data, we can see that there's a significant, considerable improvement in success rate in over 90% of cases in 2011 and 97% in 2011. And the overall abnormality rate was fairly stable at 23%. And looking at that little bit of an overall abnormality rate, that really includes all material that came in for testing from both the first trimester, second trimester, and the third trimester. And it's interesting when you look at the results from those semesters and look at the pie charts here, we had an abnormality rate of about 48% overall in the first trimester, mostly reflecting aneuploidies, not unexpectedly. The normal male results were only 13% compared to normal female results at 40%, say. And so what that tells us is that in the first trimester, particularly at the time, our dissection techniques for separating placental CVS or placental material from maternal decidua were not that great. And so that distortion in the sex ratio is a clear sign that we needed to do some improvement there. And we have made gains in that ever since. Looking in the second trimester, we get more of a better feel with there's more normal males. So that means that we're testing the right tissue compared to normal females. Still a little bit skewed, but here we're looking at fetal skin and other tissues rather than placental material. And the abnormality rate clearly drops off quite a bit to only about 9%. And then looking at the third trimester, abnormality drops rate again to 3%, not surprising. And again, there's a bit of a sex ratio discrimination here. There's many more, 70% say normal males to say 28% normal females. Don't really have a clear explanation for that, but since it's third trimester material, the results reflect just, I guess, analysis of fetal skin tissue, and it gives us some confidence that we're actually looking at the right material. So don't have a clear explanation why there's a sex discrepancy there in that data, but it is what it is, I guess. So, and just, extending that data a bit further, I've just done a bit more of a plot here from 2010 to 2020. And you can see that the overall abnormality rate here in the crimson bars of about 23%, it hovers about there to 25%. It's not much variability in that, although last year we had an abnormality increase rate of 36%. And the green bars, again, they're showing that the success rates overall are more than 90%. So it just felt right, and this is the way that we look at miscarriage material now, using microarray rather than karyotyping. And the blue line graph here simply reflects the increasing sample numbers from 2010, where we might have only been doing, say, 180 or 170, 180 products of conception testing by a microarray. It's now well over or close to 700 samples a year. And that workload just seems to be increasing. One of the limitations, of course, is using a CGH microarray platform is the confounding issue. The algorithm can't really detect changes in ploidy, so there's difficulty of distinguishing 46XX karyotype from a triploid female karyotype to a complete molar pregnancy. This is a limitation of the algorithm that uses to normalize the data and give us a result. All these sorts of results, whether 46XX, complete molar, or a female triploidy, and a normal pregnancy, a normal female pregnancy, all show a normal female microarray result by CGH array. So we knew this was a limitation. We thought, well, we needed to improve that ability to detect complete molar pregnancies and partial molar pregnancies or triploidy pregnancies. So this was a small little study that we put together in a review of products of conception material over the years of about 2013 to 2014, where we supplemented the CGH microarray with SDR analysis of microsatellites for chromosomes 13, 18, 21, for example, in order for us to get a better idea of what percentage of molar pregnancies we were missing. And this just gives us a quick little frequency plot of the abnormalities that we found. Interestingly, we had a lot of trisomy 21 pregnancies for some reason, but the abnormality rates of trisomy 16, trisomy 15, 22 sort of fit with the rest of the published literature. But what was a little bit surprising that, in about 1.5% of pregnancies, they were found to be complete moles that we would have otherwise missed before. And shortly after, the next most common abnormality after that was the partial triploidy moles that we were potentially missing. So this was a little service improvement to help improve our detection rates in products of conception material. I thought I'd just put here together a bit of a 10-year timeline of changes in technologies that we've implemented over the last 10 years. Just take you back a little bit. Back here in 2010, we implemented CGH microarrays that replaced karyotyping for POCs and stillbirth material. We were still doing karyotyping and fish aneuploidy screening in the prenatal laboratory. But shortly after that, and particularly for, if we just focus at the moment on products of conception material, shortly after that in 2014, we supplemented POC microarray analysis with Qf-Pcr. That's progressed a bit more now, and in 2017 we started using the 300K Cytosnip microarray, and then most recently last year we started using the Gsa Snip Microarray. The use of the microarray, and particularly the Gsa at a higher resolution, the resolution itself wasn't the reason for using this particular array in the POC samples. It's just that we wanted to try and minimize the number of different microarray platforms in the laboratory. The 300K microarray Cytosnip array was perfectly a good platform for investigating pregnancy and products of conception material. So while we were probably some of the early adopters of microarray looking at products of conception material, at the time there really wasn't much in the way of clinical utility or published studies on the diagnostic or clinical utility of microarray testing for pregnancy loss. But over time, this soon changed. And this is one of the first papers that I think gives a good summary of a lot of different studies using microarray for pregnancy loss. The platforms range from back microarrays to back and oligo arrays, just oligo CGH and SNP arrays, and then SNP arrays as well. And really, I think what I just want you to focus on for this summary slide is that notice the studies with the X here, 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 and here. These are all the microarray studies that specifically looked at miscarriage material. And the overall detection rate, when you average all those out altogether, turns out to be about 55, 56%. So a pretty good detection rate. This mostly probably reflects chromosome aneuploidy rather than small copy number variants. And it just, that's a good detection rate overall for products of conception. And shortly, a bit later, after this paper came out in 2007 from the American College of Medical Genetics, giving a bit more of a comprehensive analysis of use of chromosome microarrays for pregnancy loss. Not surprising, there's single common most abnormalities, a single trisomy, some monosomies in here, triploidies in here, some of the uniparental disomy, the complete molar pregnancies, again about 1%, not far from what we found when we supplemented CGH microarray with STR analysis. But interesting, copy number variants like the deletions and duplications that are pathogenic really only make a relatively small proportion of abnormalities found by microarray. And I think also reassuring is the problem with variants of insignificance when we use chromosome microarray. Again, the pickup rate or the reportable rate that considered pathogenic is really quite low. So this is a different way of looking at some of the changes, particularly across Australasia in microarray testing in POC. This is data taken from the Australasian Society of Diagnostic Genomics, their quality assessment program. And this data is the current data as of last year that I managed to get for this talk. And this is just plotting from the left, the number of samples that were investigated by microarray from 2009, which was just under 1,000 samples. And you can see that's begun to increase and particularly began to give a steep increase and more testing from about 2015 to now we're doing close to 8,000 products of conception material investigating by using microarray across the whole program within Australasia. The purple line depicts the abnormality rates for each of those years. So as of last year, over 8,000 products of conception, the overall abnormality rate is just above 35%. And just remember, there's not much granularity in this data. That abnormality reflects a whole range of first trimester, second trimester, and third trimester pregnancies. And I thought the last slide before I moved on is just to mention about some of the limitations of microarrays and to remind everyone that, detection of balanced structural rearrangements are not possible. Small marker chromosomes that we often have previously characterized that probably contain only centromeric heterochromatin with very little euchromatin and often consider them harmless, that we'd other characterized by NOR staining or sebum. We won't detect those in the probe coverage from the CGH microarray or the SNP array data. Mosaicism can be an issue with abnormalities less than 10 or 15%, could go undetected. And as I've mentioned before, the array CGH platforms have limited ability to detect ploidy changes. And of course, also interpretations of variants of uncertain significance can cause some anxiety and confusion in reporting in products of conception. But moving on from array CGH platforms, I think most of us working in this space are in agreement that probably SNP microarrays are considered far superior for CGH array, looking at products of conception and pregnancy material in general, mostly because they have better ability for identifying triploidy and molar pregnancies, mosaicism, and contaminating genotypes, which usually reflect maternal cell contamination. And even though it's there, if it's in less than say 10 or 20% of the sample overall, and you've got a clear aneuploidy, you can still report these results. So for these reasons, I feel that the SNP microarray approaches for investigating pregnancy tissues is the best platform or a better platform to go forwards. So let me just change tactic a little bit now and talk about prenatal diagnosis. Again, I thought I'd throw in this slide with the timeline and really looking about prenatal diagnosis now. And to take you back 2010, say, 10 years ago, we were certainly doing karyotyping in fish, rapid aneuploidy detection for the major trisomies. And that's about the time when I joined the laboratory. And around about that time, particularly in 2011 and 2012, non-invasive prenatal screening using cell-free DNA began to emerge globally in prenatal diagnosis laboratories. And really in Australia, although it was emerging, there weren't any labs locally performing this testing. And most of the testing, or all the testing at the time, was sent to the US laboratories or perhaps over to Asia, to Hong Kong. But with that, and that change brought more interest in prenatal testing. And we also, by about 2012, weren't getting into the cell-free DNA testing space, but we did transition from FISH to Qf-Pcr for rapid aneuploidy detection, mostly due to resource issues. I feel Qf-Pcr is a simpler and more scalable test than FISH analysis. We began moving into using CGH microarray in 2014 and 2015, and certainly we released our CGH microarray service for prenatal diagnosis in 2015, which replaced karyotyping. And that space has now moved on, and we started to use the 300K Cyto Snip array in 2017. And in a similar way, in 2020, last year, we migrated to the Gsa Snip array. Not because it has more probes and increased coverage, but just we wanted to uniform and try and reduce the number of different microarray platforms that we had in use. We had an 850K Cyto Snip, we had a 300K Cyto Snip, we had an 8x60K CGH adjuvant array, we had a 400K CGH adjuvant array, and we had some other array platforms. And organizing the workload and prioritizing testing was just getting complicated. So the laboratory now is trying to move as much as possible to the Gsa Snip array, just a uniform testing that can be applied to all different prenatal, postnatal, POC investigations. So I just thought I'd take us back a little bit. What are some of the reasons or main indications that we want to do prenatal diagnosis? In years gone by, it's been the primary indication has really been advanced maternal age. I'm talking, maybe 15, 20 years ago when there weren't many screening programs around. But certainly ultrasound examinations of pregnancy and measuring mucofold and also fetal structural morphology is becoming an important and primary reason for performing invasive prenatal testing. And some of the other reasons for prenatal testing might be there's a previous history in the family, or a parent is carrying a structural chromosome rearrangement, so that's the reason for prenatal invasive testing. But I think what's really revolutionized prenatal diagnosis in my time is the gradual emergence of greater and more effective non-invasive screening tests. And the main ones that come to mind for me are the maternal serum screening test in the first trimester, and then which was sort of emerged in about the early 2000s. And more recently, non-invasive prenatal screening using cell-free and DNA, and as I said, which began to emerge in 2011 and 2012. I feel these have been real game changers in the last 10 years, 10, 15 years in prenatal diagnosis. I can't neglect the second trimester triple test. That was certainly available in Australia in the mid to late 90s. But I think for me, these particular tests have really been game changers. So what typically happens if you get a high risk or a positive screening test, it's an indication then for invasive sampling. And just to refresh everyone's mind, we can do chorionic villus sampling in the first trimester, usually between 10 and 14 weeks gestation, or we can defer it until the second trimester and perform amniocentesis, typically from about week 15 onwards. Most women would access amniocentesis between 15 and 18 weeks gestation. And what sort of testing do we do once we do that invasive testing? Well, for cytogenetics, it's going to be classically the G-band karyotype. You may want to do rapid aneuploidy detection by FISH, Qf-Pcr, or Baxon beads or bobs, as it's sometimes known. And then more recently, CGH or Snip Chromosome Microarray. So they're the diagnostic tests that we're going to do in the cytogenetics laboratory. But, you know, although I'm talking about using microarrays in prenatal diagnosis, what's so wrong with a good old humble G-band karyotype? You know, it still has its place. It's going to detect the major abnormalities. And I'm talking about the trisomies of 21, 18, 13, and the numerical X and Y chromosome abnormalities. You can detect triploidy and tetraploidy. You can detect gross unbalanced structural abnormalities, and there's some important level 3, likely true fetal mosaicism abnormalities that you're going to be quite confident to detect by the G-band karyotype. And you might pick up some other words, what are called minor or unexpected abnormalities, you know, the balanced structural rearrangements, the translocations and versions. You know, they're important, but they're probably not going to be the major reason if there's a fetal structural, abnormal fetal structural morphology scan or a high-risk non-invasive screening test. There's also the emergence of, you know, the level 1 or 2 mosaicism that we see in the laboratory with cultured karyotypes. You've got to try and work through those. They're a bit difficult. They're usually not of that much strong importance or significance for fetal pathology, but we still need to work through them. Of course, all these are confounded by the presence of confined placental mosaicism. When we find either a level 1, 2, or 3, even 3 mosaicism, we have to work through all that. But having said that, just want to remind everyone that, you know, prenatal diagnosis by G-band karyotype was the gold standard for many, many years. It's typically, as you know, we've already talked about, it's performed after 15 weeks. There's a small miscarriage rate, quoted about 0.5%. And certainly, I pulled this is a bit of an old slide that I've had together. You know, if we look at some meta-analysis of randomized controlled trials from the Cochrane database of systematic reviews, you know, G-band karyotype by amniocentesis is very, very accurate. There's very few false positive rates. And in those 3 randomized control trials, I think there were over 7,000 pregnancies looked at, there were no false negative rates. And really the high accuracy and reliability of the G-band karyotype reflects the mix of populations that we find in the amniotic fluid. So we're looking at cells sloughed off from the amniotic membrane, skin, gastrointestinal tract, and the urinary tract, and the fetal skin. Yeah, sorry, I mentioned the fetal skin. In a similar way, the G-band karyotype using chorionic villus sample is also quite accurate. You know, the main benefit of using CVS material is it brings prenatal diagnosis into the first trimester and offers an easier way of doing termination of pregnancy if it's required. And some of the classic cytogenetic tests that have been used in the past, and particularly try to get a quick result, has been the short-term or direct CVS culture, where you're trying to look at the karyotype of rapidly dividing trophoblast cells. But more importantly, and probably the more reliable test, is the long-term culture, the chorionic villus, chorion mesenchyme core. Results are longer, takes 10 to 14 days to get a routine result, but associated with much lower false positive and negative results. I really, in Australia, struggle to find laboratories still doing direct and short-term cultures. But for those labs who do them, it's certainly best practice that any results obtained from a direct or short-term culture in CVS should be confirmed by long-term karyotyping to reduce the risk of false results. Some of the limitations, the slightly higher miscarriage rate, but have a think about that miscarriage rate, 0.5 to 1%. I can certainly tell you in Australia, if there was a private obstetrician or anywhere who had, for every 100 invasive procedures they did of CVS, had a miscarriage related to the procedure, I don't think that would be in practice. These are old data. I think miscarriage rates are much lower than this, and there's some evidence out in the literature for operators doing amniocentesis or carrying villus sample who are skilled and trained well. There's little difference in the overall miscarriage rates between either CVS invasive procedures or amniocentesis. And of course, I've mentioned previously, confined placental mosaicism can be an issue of 1 to 2%. But really, overall, going back to the Cochrane database of systematic reviews, still a very highly accurate test, slightly higher false positive rate of 0.58% and a little marginal false negative rate. But overall, GBM karyotype of chorionic villus sample is very accurate. Again, just refresh again using GBM karyotype, the main limitations. It's really about getting viable tissue and cell culture. This test is very labor intensive. They can be confounded by maternal cell contamination. So there needs to be, best laboratory practice around how to minimize that, whether it's dissection of chorionic villus or if it's blood-stained amniotic fluid, culturing out fibroblasts and trying to get rid of as much of the red blood cells as possible. And of course, these days, one of the important limitations is abnormalities below 5 to 10 megabases of genome or cryptic abnormalities are not detected, including copy number variants. Although laboratories are pretty good, again, the overall results are usually not available before 7 to 14 days with a karyotype. So why did I mention that last? Well, it gave me an opportunity then to just talk a little bit about the emergence of rapid aneuploidy detections. And there are two main techniques that are probably used in laboratories, mostly in Australia. And these are the fluorescence in situ hybridization, or FISH, or quantitative fluorescent PCR. Most laboratories use FISH. I think for cytogenetic laboratories, it's probably an easier transfer to use cell-based FISH testing rather than using molecular testing by quantitative fluorescent PCR. Both these tests give rapid diagnosis of the 5 common aneuploidies. And the reason this is such a good rapid test is, of all the abnormal prenatal results that we find in the laboratory, 90 to 95% of those abnormalities comprise the aneuploidies of these 5 chromosomes. So it's a very good, highly clinical utility rapid test. Results are available in about 1 to 2 days. Sometimes we can do it the same day. And the beauty is that they don't require cultured cells like conventional cytogenetics, but they have the limitation that other aneuploidies, mosaics, and structural rearrangements are not detectable. Now, FISH was introduced back in the early 1990s, and there's been a lot of studies over that time that it is a highly accurate screening abnormality, rapid aneuploidy test. And in a study by Tepperberg back in 2001, published on the largest series and multi-center study of over 29,000 samples, the sensitivity was high, the specificity was high, and importantly, the positive predictive value. So if you got an abnormal result, the probability that the fetus was affected by an abnormality was 99.8%. And if you got a normal result, the negative predictive value was 99.4%. So, if you got an abnormal result, you could be very confident that you had a fetal abnormality. If you got a normal result, you could be very confident that the fetus was not affected by any of these 5 major aneuploidies. When we look at Qf-Pcr, we're looking at SDR markers and ratios. And usually in a normal result, we want to see heterozygous peaks like this in a 1-to-1 balanced ratio. we're looking for trisomy, we want to see either a triallelic pattern, again, with the peak height or the peak areas in a 1-to-1 area ratio, or in a 2-to-1 ratio. So these are the classic signs that we look for trisomy. And again, several large studies have shown high sensitivity and specificity. And one of the largest studies published back in 2010 on 9 years experience and over 43,000 samples, again, showed the sensitivity was high, not quite as high as FISH. The specificity was good, but importantly, you know, the positive predictive value and the negative predictive values were also very high and very, so if you got an abnormal result again, you could be confident that you had an abnormal fetus. If you had a normal result, you were confident in the normal result. The main advantages that I find for this particular test, and perhaps why we moved into using Qf-Pcr over FISH, it's a simple and quick PCR setup. It can only take, you know, takes only 15 to 20 minutes, whether you're using one sample or say 4 or 5 samples. It's relatively fast, it's not labor intensive, and we found that this could work quite well for us. There is one kind of major limitation that I feel is that, you know, the detection limit of mosaicism is probably about 10 or 30%, which could go undetected. But I guess another offshoot of that, or another contrary reason for doing Qf-Pcr by STO microanalysis, is that we can also detect maternal cell contamination in the sample if it's significant. Again, so just a quick snapshot, we replaced FISH with Qf-Pcr back in 2012 and still use it today. So I'm going to just digress sideways a little bit. I'm not going to speak extensively on non-invasive screening tests, but I wanted to just make point of this because they are important in helping to target general obstetric population and identify pregnancies at high risk of fetal chromosome abnormalities so that we can do more target invasive testing. And these are the two major tests that I feel, as I've said, made a huge impact in prenatal diagnosis from about the early 2000s and later in, say, 2011, 2012. So the combined first trimester screening test, you know, for trisomy 21, it really is a very highly effective screening program, and it was introduced into Australia in the early 2000s. You know, it uses biochemistry markers such as free beta, human chorionic gonadotrophin, and pregnancy-associated protein A. And we look at multiples of the median of the population to modify, use those biochemical markers to effectively modify the maternal age risk for trisomy 21. And it becomes extremely powerful as a screening test when you incorporate measurement by ultrasound of the fetal nuchal fold, or sometimes referred to the nuchal translucency measurement. You know, and using a high risk cutoff figure of 1 in 300, you know, those women who have a higher risk will screen positive in 5% of the general obstetric population. And in that group, the sensitivity for trisomy 21 is about 90%, with a very good specificity of 99%. So while 5% might sound like a, you know, 5% false positive rate might sound not very reasonable these days, particularly compared to cell-free DNA. At the time, it was a very, very good risk cutoff and a screen positive rate, because even though it narrowed the number of invasive testing done, and for those women that got a negative result, the NPV value was really high. You could be quite confident with a negative result that your pregnancy was not going to be affected by trisomy 21. For those 5 to 6% of women that did screen positive, the positive predictive value was only 5%. And again, that doesn't sound very impressive, but if you think about it, 5% of the general obstetric population could screen positive by this test. And of those women, they had a 5 to 6% chance that their pregnancy was affected by trisomy 21. So the majority were probably still unaffected by trisomy 21. So there's still some power in that test, and it was very effective at the time, and it revolutionized first trimester prenatal diagnosis. It brought second trimester amniocentesis, particularly in Australia, right, and it changed that paradigm to bringing testing into the first trimester. And my laboratory at the time, over 10 years ago, when we first introduced first trimester screening, we saw a dramatic change and a rebalance amniotic fluid referrals to chorionic villus referrals. And it made a big impact to the private clinics that we were serving. I think I've already commented about this, that I felt, this particular screening test revolutionised first trimester diagnosis in Australia at the time. It also allowed early ultrasound assessment for fetal and placental abnormalities and provided an option for first trimester termination and improved maternal health risks overall. So what about cell-free DNA and non-invasive prenatal screening as we know it now? So the first clinical validation study was reported by Chu in 2011 with really good sensitivity, excellent specificity with a very small false positive rate, but the positive predictive value was impressive, 96.6%. So if you got a positive NIPT or NIPS result for trisomy 21, it's pretty certain that you were going to have a trisomy 21 affected pregnancy. The reverse is really impressive well. So if you got a low risk result by NIPS, the negative predictive value was 100%. So again, if you've got a negative result, low risk result, the chance of your pregnancy being affected by trisomy 21 was very, very reassuring. Not being affected by trisomy 21 was very reassuring. And certainly, while that caused a lot of interest, 3 large US multi-center studies with international collaboration certainly confirmed those findings with very low false positive rates. And I guess I wanted to present this slide at the time. This is data from around about 2011, 2012, which did a summary of the major publications at the time and laboratories doing NIPS that overall confirmed a very, very high sensitivity, very, very high specificity for the overall detection of trisomy 21. There was, it was early days, there was still some high failure rates, but overall, pretty impressive test. And so at the time, this led to the International Society of Prenatal Diagnosis releasing a position statement in 2012, indicating that, NIPT or NIPS, is now probably better known for, should only be offered for high-risk pregnancies and not low-risk pregnancies. And while this test was very popular and still is, there was early suggestion that why shouldn't you offer this test, to all pregnant women in the general obstetric population? There were some reasons for that, probably because of cost, and most, I guess, prenatal screening programs, particularly in Australia, probably couldn't afford rolling that out to everyone. There was also a lack of best practice guidelines and data at the time. But the important thing is that you really need to understand that these screening programs rely on the prevalence of disease. So the prevalence of the chromosome abnormality in different risk pregnancy groups affect the effectiveness of NIPS screening. And there was also some controversy about, why should NIPS replace combined first trimester screening, which was so effective? And there were other groups that were proposing that you shouldn't get rid of combined first trimester because of the advantage of assessing placenta and fetal structure, in the first trimester. And so, so groups either in the UK and some led by here in Australia were proposing that we use a contingent model. And this contingent model is used by quite a few laboratories and prenatal diagnosis centres here in Australia, where they still do a confined fetal trimester. And if you screen high risk, you could go on to either NIPS or invasive testing straight away. But if you screen low risk by the combined fetal trimester screens, that's you can be very confident that your pregnancy is not affected by Down syndrome or the other major abnormalities, and that can be the endpoint without the need for invasive testing in low risk women. So I'm just checking my time here. Okay, so I'm going to try and hurry this along and talk more specifically about chromosome microarrays in prenatal diagnosis. So, maybe it's no surprise to anyone in the audience that, microarrays are well established now in investigation of childhood causes of congenital abnormalities, intellectual deficit, etc. And this consensus statement first came out in 2010 by the American College of Medical Genetics. What it was proposing was that, microarrays should be used in postnatal work, in childhood assessment of development delay, intellectual deficit. But this led to some people proposing, the use of microarrays in prenatal diagnosis, but it was highly controversial at the time. And partly the reason is because of the interpretation of copy number variants and pathogenicity and what that means for a pregnancy, particularly how to interpret and convey the anxiety and deal with couples over variants of uncertain significance or incidental findings. That was quite contentious. And there were no clinical utility studies before 2011. There'd been some small scale investigation studies, but nothing really that demonstrated or proved clinical utility. But that soon began to change from about 2012, where clinical utility started to be demonstrated in high-risk pregnancies and low-risk obstetric populations. One of the first of these was published by Wapner in the New England Journal of Medicine. It was a large study of over 4,000 women from 29 centres with a variety of prenatal indications from advanced maternal age, screen positive tests, and abnormal ultrasound and other indications. But the overall summary was that, in the ultrasound abnormality group, there was an additional 6% abnormalities detected over karyotyping. And there was about 1.7% additional abnormalities detected in the advanced maternal age group and positive Down syndrome screening group. So that was kind of reassuring. And then there was another study shortly after by Hillman, looking at a small prospective cohort of about 243 women. And they did a meta-analysis of about 25 previous prenatal studies. And overall, their conclusion and summary was that there has an increased abnormality rate of about 7 to 10% over karyotyping. And then a little bit later, more or less maybe that same year, Schaefer and Rosenberg published a summary of different microarray studies, various sizes, and compared the abnormality rates. And I think most impressively is that, again, consistent with other studies, that the detection rate of pathogenic copy number variants and abnormalities is around about 7% over and above karyotyping. And that's represented here by the blue diamonds. The red boxes represent the abnormality rates in the advanced maternal age group, and that's the maternal serum screening group, and the green diamonds represent the advanced maternal age group. So just showing that there's a wide range of abnormality rates across different studies, I guess, providing evidence of clinical utility in prenatal diagnosis. And a further breakdown from those studies shows that the major abnormalities, really focus on those with ultrasound abnormalities, with multiple ultrasound abnormalities, hollow prosencephaly, brain defects, skeletal defects, and overall cardiac defects. So this led us to around about that time in 2013, 2015, to start thinking about using microarray for prenatal diagnosis in our laboratory. And this is a small validation study that we published back in 2016, where we used a 60K ISCA targeted CGH array on CVS and amniotic fluid. We only looked at high-risk pregnancies with fetal structural abnormalities, nuchal fold measurement greater than 3.5 millimeters, and those with screen positive tests by first trimester screening. Overall, we had about 202 high-risk pregnancies. The majority were amniotic fluid samples with about 46 CVS. And really, I think what I want you to take over is that the overall microarray abnormality rate was about 24%. This included all the major aneuploidies. If we excluded it, it dropped down to about 9%. And the abnormalities that we found in addition to karyotyping or that weren't detected by karyotyping included pathogenic CMVs in 4% of cases and variants of uncertain significance in only about 3.5%. So overall, this gave us an overall additional yield of about 7.5% copy number abnormalities not found by karyotyping. Again, consistent with all the studies that were previously reported. When we looked at the sensitivity and the positive predictive values and the negative predictive values, we're also quite confident that most, we had a sensitivity 94%, positive predictive value of 100%, and a specificity of 100 and a negative predictive value of 98. Overall, there were no false positive results. We did have some false negative results, but when you look at those and think about what they might mean in terms of fetal significance, we had a level 2 mosaic of trisomy 21. You know, this is a trisomy 21 seen in 2 or 3 cells in one culture vessel. We needed to follow that up, but probably wasn't a major concern for the pregnancy. We had a 69 XXX female, but we missed that, but we'd detected we knew it was there because we'd done Qf-Pcr analysis. We had a marker chromosome that was likely only centromeric and of no significance. And we had 4 balanced translocation and all were found to be inherited. So this led us to, in 2015, to be confident that we could replace fetal karyotyping with CGH microarray. So how has all this changing laboratory practice and screening programs impacted invasive prenatal diagnosis in Australia? I'm just going to present a couple of historical data sets. This is data that was published back in 2016 by Lisa Huey. You know, on the left graph here shows the reasons for screening methodologies for invasive testing. And, you know, we can see here in, you know, the mid 70s, late 70s, that the major reason was advanced maternal age. And by about the late 80s and 90s, this began to fall off. But the part of the reason for that fall off is the emergence of screening programs like using ultrasound abnormality detection. And then a bit further along in the early 2000s, where I've mentioned, you know, we had the emergence here of combined first trimester screening, and it really took off. And corresponding with these non-invasive screening tests is the overall reduction of invasive procedures based on AMA. And certainly by the early 2000s, that AMA was no longer the primary reason for doing invasive testing. And on the right here, we can just see the number of overall invasive procedures. I forgot to mention that this is just data, a snapshot from the state of Victoria between 1976 and 2013. It's reflected across Australia overall, but you can just see, you know, by the mid 90s, late 90s, invasive procedures peaked, and ever since they've been falling. This is a little bit the same data, but a closer snapshot here. I want to just show the emergence of NIPS, or cell-free DNA screening. Again, it started to kick up dramatically from 2013 when local laboratories started offering the service, and it's overtaken, and so is ultrasound, and still combined trimester screening started to fall up, but these are still major important screening programs in Australia. And overall, what this is effectively meant is that, you know, population testing, invasive procedures continues to fall, and even more so from 2013. But the abnormality rates for the major trisomies and then copy number variants by introduction of CMA has really increased significantly. So what this is showing is screening programs have been effective in Australia. It's reduced the number of invasive testing, but the abnormalities and the target abnormality rates are being picked up in a better way. Again, coming back to the Australian Society of Diagnostic Genomics and their data sets, really this is just giving a comparison of chorionic villus samples on the left, the number of actual GBA and karyotypes. You can see there back in 2000, we were doing over 5,000 as a program, Australasia overall, you know, looking at 20 laboratories throughout Australia, New Zealand, Hong Kong, and throughout Malaysia. You know, these invasive karyotype GBAN testing peaked at 2009, and then followed by improvements in non-invasive screening. The number of invasive testing started to fall, and particularly from 2013 and 15, they begin to fall dramatically, considering that only last year, only 830 samples of a CVS invasive testing had a GBAN karyotype. The over-invasive rate was still over 2,500, but only 830 had a GBAN karyotype. Similarly, if you look at the amniotic fluid karyotype data, you know, back in the early 2000s, we were doing over 20,000 GBAN karyotypes in amniotic fluid. And the emergence of non-invasive testing, and NIPS in particular, say 2013, really started to drive down the number of GBAN karyotypes that we were performing overall within the program. But apart from the drop-off, look at the increase in the abnormality rates, particularly for the CVS. So last year, although only 830 GBA karyotypes were done, over 80% were abnormal. Similar trend in the amniocentesis, much more higher detection rates in these GBA karyotypes. So I just want to say, apart from the screening programs having more targeted stratification of high risk versus low risk pregnancies for fetal chromosome abnormality, the other major contributor to this, of course, was the emergence of chromosome microarray. And again, this is some data from the QAP program collected over the last 10 years. You can see the number of labs and the number of samples being analysed by microarray for CVS samples really began to take off since about 2015. So of the majority of invasive CVS procedures, the majority of these have microarray testing now rather than GBA karyotype. In a similar way, you know, of the over 7,000 invasive procedures done or reported within that program, you know, more than 5,000 are having microarray done rather than a GBA karyotype. So I just would like to finish in closing, you know, that's the story that I have to tell about prenatal diagnosis and my experience of the last 10 years. But it makes you think about what's next. You know, there's been much advancement in cytogenetic testing for chromosome abnormalities. There's probably some improvements in the time we can report results and that sort of thing. But I think where the next phase of prenatal testing, it's going to be more cell-free DNA analysis of particular targeted variants, like, you know, rhesus factor, or, you know, maybe a paternal carrier of a mutation, a parental carrier of a sequence variants that we might move into cell-free DNA. And then also, I think the biggest change is going to be using a whole exome, a whole genome sequencing in the prenatal setting. Now that brings a whole other discussion about the pros and cons and the difficulties in that. But I feel for my laboratory working in the cytogenetic space, that's probably a space I'm not going to go into. That's more in the realms of, say, some of the molecular genetics or the genomics laboratories who want to move into that space. So I just want to make an acknowledgement in closing to the Australasian Society of Diagnostic Genomics Quality Assessment Program for access to the data, and thank you for listening. Thank you. Over to you.
Thank you so much, Dr. Dale, for the detailed presentation and the insightful talk.
My pleasure.
So as expected, we have lots of questions regarding the talk. I'll just take the privilege to ask the first question from my side. So from the timeline, I can see that from last decades or so, more than a decade, you are using multiple technologies, and you have really seen a paradigm shift in the era of different technologies. So can you please highlight what is the considerations for you to decide, like, at this particular point you have to use this technology and this is the right time to switch onto a newer technology?
Yeah, I think for me, some of the major reasons for changing technologies is process efficiencies, using the best or getting the most out of my staffing resources and my budget. It's always a constraint. I think laboratories worldwide have this problem. I feel it particularly where I am. And I mean, and part of that is, you know, always looking for better ways, improvements for testing, process efficiency, you know, work process efficiencies, but also making a responsible choice on the clinical utility of those tests. And for me, I think the biggest change was moving from karyotyping into CGH microarrays. It was quite contentious at the time, back in 2014, 2015, particularly even in my institute, because it was just emerging. But I think time has proven very shortly afterwards that it's now considered best practice in prenatal diagnosis. The feeling is, where I am, if you're going to put a needle into a lady's tummy to do an invasive procedure with the risks of miscarriage, you apply the best test. And we feel that the best test where we are is rapid aneuploidy detection by Qf-Pcr or FISH and a microarray.
Okay. So from the attendees, Neha wants to ask, is the microarray CGS data that has been discussed is on Illumina platform? And if yes, which chip which microarray chip basically you have used for prenatal diagnostic application?
Yeah, the chips that we've used is, like I said, the 8x60K CGH array, the ISCA design back in 2015. We then moved to the 300K Snip Biolumin, the B chip. That's a very effective multiplexable array. You can do 12 samples at a time. We really liked that. And more recently, we've moved to the Gsa platform, and at the moment, we're evaluating, probably going to move to the new Gsa Snip chip that Peter spoke about at the beginning of the presentation.
So basically, as Illumina has launched new chips, you have shifted your microarray technologies as well during the time frame. So next question is from Priyanka. So she's asking, most of the times POCs are MCC positive. So how to proceed further? Any suggestion from your side?
Sorry, say that. Can you do the question again?
So most of the times POC are MCC positive. How to proceed further? Any suggestions from your side?
So if I understand the question, for most of the time, if the Qf-Pcr is positive,
POC samples.
CVS samples?
I think it's, Dale, I think it's the question is, I think around POC samples having maternal cell contamination and how to proceed further, if you have any suggestions around that.
Right, right. So for me, placental material in particular, you need to spend the time up front to try and dissect out as much good quality, visible chorionic villus placental material from blood clots and maternal decidua. And there are ways that you can do that. You need to do that by using a stereo microscope or a microscope with fiber optics where the light's coming down, so you can get a good visual look at the morphology of decidual material versus chorionic villus placental material. There is a distinction. In some samples, it's very easy to distinguish the placental material, particularly if you have a lot of it. But if you've got a macerated pregnancy or a placental tissue, it can be really difficult. If in doubt, don't proceed. So we had some issues early on where you probably, in my earlier slides, we had a lot of normal females. So a lot of that's probably contaminated by maternal decidua. And our dissection and our criteria and our cutoff for rejecting samples wasn't high enough. So we soon after we saw that data started to think, you know, we need to be a bit more stringent. If we had any doubt about a macerated tissue, we just didn't do the testing. We rejected the sample.
Okay.
And so I'll ask the next question. The next question is, did you face any challenge in transitioning from traditional technology to microarray?
Yes. And I think the biggest challenge is, we were fortunate that we had a well-established postnatal microarray platform that we knew really, really well. And so the transition to start using prenatal samples technically wasn't really the issue. I think the barriers there were, how do we interpret copy number variants in a prenatal sample? And particularly those that, of course, most of the time we're going to find a variant of uncertain significance. And how do we return that to the clinician with confidence and interpretation for that? So that was the biggest challenge, and also getting clinicians used to, or obstetricians used to getting that information returned and then conveying it to couples and how to manage pregnancies and follow up from that. So a couple of ways that we help overcome some of the barriers there is that we tried as much as possible to ask for parental blood samples at the time of invasive prenatal testing. So we didn't have to go back 2 or 3 weeks later to say, oh, we found this finding, we need to follow up now with parental samples and counsel the couple and get the blood samples into the lab. And then another week to do the testing and convey the result. So the idea is doing the prenatal sample. If we got a result that was a variant of uncertain significance, how do we interpret it? Okay, we'd run the parent samples. If we found it was inherited, more than likely that's a likely benign variant, and we would report the 3 results together. So that was one way to help overcome that barrier. Other referrers, we didn't get the samples and we just had to navigate that at the time. We had to report the variant, then get the parents in, run it. If it was inherited, we'd then report it as probably a likely benign variant. and unrelated to if there was any fetal abnormality. So that was probably one of the major hurdles to transgressing into CGH array. And also, I guess the other way to help reduce the number of variants of uncertain that we reported, we set a size limit. So we didn't report deletions below a size of 400 kb at the time. And we didn't, 200 kb for deletions. And we didn't report duplications at a level of 400 kb or less. Okay, so that, whereas in our postnatal, we would report much smaller stuff, but in the prenatal setting, we didn't. And actually more recently, we've just reviewed our criteria. So now we're not reporting deletions less than 500 kb in size, and we're not reporting duplications less than a megabase in size. So we've upped it up a level again because we feel that we're confident that things smaller than that are probably not related to the fetal pathology or the fetal abnormality. The exception is if we find something, we've got a known haploinsufficient gene or a triplet sensitive region that's associated with a known clinical syndrome, we would then report those sorts of things. So it's really being clear of the pregnancies that you want to target with CGH array or SNP microarray, and having a good confidence around your reporting criteria. And also look at, I think I didn't include it in these slides here, but also looking at, there's some other international published recommendations on regions not to report and copy number variants to report, and also how you might want to deal with those regions that are known as susceptibility loci. And a classic one is the deletion involving 15q11.2 involving NIPA1. So the deletion and the duplication. The duplication we don't report even in our postnatal work, but in our prenatal work, we were reporting the NIPA1 deletion variant for a while because it had been associated postnatally with some autistic or learning difficulties, but we've actually stopped reporting that in the prenatal setting because we no longer think it's that important. So be clear about your reporting criteria, and that helps you overcome some of the barriers.
Yeah. So the next question is, what important points should be considered while collecting a sample in preventing bacterial contamination?
Oh, okay. So I think I guess I'm not an obstetrician doing the invasive procedures, but if you're going to collect amniotic fluid, I think that's probably not as much as a risk factor. You know, obviously you're going to swab the invasive site and collect that under sterile conditions as best you can and get it to the laboratory as soon as you can. I think part of this is getting the samples to the laboratory as soon as possible. Collection of CVS samples, you know, you can collect them in transport medium and they can have some antibiotic in them. I think the important thing is about reducing bacterial contamination. It's once you get it in the lab. And so I don't think it's terribly difficult about the collection, and sometimes samples do become contaminated, but have your cultures, cell-based cultures systems set up if you're doing karyotyping or even backup cultures, because even though we do microarray, we've always got a backup culture. So have your culture system set up with appropriate antibiotics, antimycotics to suppress that. And if you do get an emergence of contamination, you need to have your own laboratory processes to control that, you know, discarding cultures, swabbing down incubators, and trying to get rid of that contamination as best as possible.
Yeah, I had a question that I posted to everyone by accident, but you know, you saw the products of conception referrals, the dramatic rise. I wanted to ask whether that was an increase in referrals for some reason, or was that an increased ability within the laboratory to process more samples?
Yeah, look, I think it's more the former, and I don't have a clear explanation for that. And I think it's partly change in best practices for obstetricians and people who are accessing reproductive technologies or assisted reproductive technology, you know, IVF. More and more couples are going to IVF specialists, and those people are a cohort that often have miscarriage, and they want to know why. And certainly, while we used to only perhaps do 3 or 4 products of conception investigations by karyotype on array a week, we're finding we're getting up to 15, 20 POCs a week at the moment. It's growing. And I think that's partly the referral base. It's medical specialists, whether they're IVF specialists or their obstetrician, knowing that or becoming more aware of how important chromosome abnormalities are, and there are causes for that. And if you do find an abnormality, it can be reassuring to the couple that the next pregnancy you have is probably going to be a normal pregnancy, because these are sporadic abnormalities. They're not recurrent miscarriage. It's different for the couple that have recurrent miscarriage and there's no abnormality, because it's not chromosomal. There's something else going on. So again, that's useful information to have. So I think the answer is related to your first question rather than the capacity of labs to do it.
So the next question I think is quite topical for you, because I know in just talking to you earlier that you've recently undergone NATA accreditation, which for the audience is an accreditation required for diagnostic labs in Australia. So this question is, how do you determine what resolution your lab reports in terms of mosaicism and also CNV using microarray?
I think the question comes back to the clinical question of interest. For a postnatal situation where we're looking at childhood disorders, congenital abnormalities, intellectual deficit, autism, behavioural disorders, we're going to want to use a relatively high resolution array that's easy to use. We don't have a particular size cutoff threshold for reporting a deletion or duplication. We even report deletions or duplications in gene deserts. Okay, so where we think there are no genes of interest, but we do report them because you're not sure what regulatory elements are in there from the microarray data, and we follow those up. So that's I guess part of the question there, Peter, is we go higher in the postnatal setting, but at the same time, and say you also don't want to have to investigate every copy number that's called on the array platform, because it ends up being a lot of noise, and the smaller the copy number abnormality is, the more likely it is benign, because it's just in the background of our DNA and it's not really, or most of the time, it's probably not pathogenic. So you need a filtering mechanism or a reporting guideline about what resolution you're going to report at. So that's, I think, probably the driver or the answer to that question. And in the prenatal setting, we've taken that even further, is although we're using a high resolution array, so the GSA array, the reason for that is not the increased resolution to find smaller deletions in the prenatal setting. We've set guidelines about levels that we don't report under, so 500 kb for the deletion and megabase for a duplication. For us, it's about having some uniformity in the platform design, so we're not running 3 or 4 different microarrays and 3 or 4 different microarray batch runs a week. We can streamline it all into one platform. Well, that's where we're heading to at the moment, to make our lives a little bit easier.
Yeah, now I'm not sure we're going to get through all the questions today, because you've been very fantastic giving us your time, but I'll ask you another question, and then I'll refer back to the Premas team, okay? So this question is, we had a few false negative results with karyotyping, which were found to be positive in Qf-Pcr. What are the possible reasons for a false negative in karyotyping? And then what should be the next clinical step if such a result is received?
Yeah, okay, so that's a pretty broad question. And I think it might come back to the type of tissue you're looking at. So, amniotic fluid, it's probably, if there's a discrepancy there, maybe there might be some maternal cell contamination in there. You might have grown out normal female tissue compared to the Qf-Pcr, which might more likely just have captured fetal amniocytes. It's difficult to say without knowing the exact scenario, but I think the issue is more explainable, or using chorionic villus sample, where again, you know, you might, if you're using cultured material in chorionic villus sample, you're culturing the mesenchyme core. It's a very stable and more reliable tissue to get a karyotype. If you're using Qf-Pcr on that tissue and you haven't removed the cytotrophoblast or the trophoblast layer, so you've got the mesenchyme core, which is the stable tissue of the villus, and you've got a little thin sleeve of cytotrophoblast or trophoblast material across that. And that's rapidly dividing, and we well know that that tissue can give false positive results for a trisomy. So that could be one explanation, that you've used the whole villus and not removed the cytotrophoblast, or simply you've sampled a part of the placenta where when you've divided in the lab, you've got some that's got a trisomy cell line in it and the other one has got more normal cells, and you've grown out the normal cells rather than the abnormal cell. So I guess it depends on the situation, the material you're looking at.
Gsa, do you want to come back on?
Sure. Thanks, Peter. Thanks, Dr. Dale, for answering all the queries. So I understand that there are some questions which have left unanswered because of the lack of the time, but we will contact every person separately and try to answer their queries in detail. And at the end, I would really like to thank Dr. Dale for accepting our invite and giving the insightful talk to all the attendees. And thanks, Peter, for organizing it. Thanks all the attendees to attend this event. We look forward for your support in future. Thank you. Thank you, everyone.
Okay. Bye. My pleasure.
Bye-bye.
Bye.